Hello, everyone, and welcome to the Lipedema Patient Roundtable. It is March, and we are marching forward. It's so interesting. We had scheduled this webinar before Oprah's show was scheduled, and we are so excited to be talking about some of the medications that are available for obesity. And does this apply to lipedema patients? We want to know, and we've got answers coming from Dr. Nick Pennings. Dr. Pennings, first of all, thank you so much for being here.
Well, thank you for having me.
Could you give us a little bit about your background, your affiliation, how we found you, and where people can find you?
So I'm a family physician, and I practiced in private practice for 22 years, and then I moved into academic medicine. At the same time, I also became board certified in obesity medicine. And one of the things I wanted to do in academic medicine and teaching in a medical school was to teach about obesity, which I was able to incorporate into the curriculum. So I'm board certified in family medicine, obesity medicine. I actually have fellowship designation in both. And I am an associate professor and chair of family medicine at the Campbell University School of Osteopathic Medicine, where I've been for 10 years now. And there I get to work with students. And I also have a clinic that is associated with the school.
Mm.
There I see patients for treatment of obesity and more commonly now for evaluation and treatment of lipedema. So that has been an exciting shift for me to be able to uh, see more and more patients and try to make more and more of a difference in this world.
So that just warms our hearts, all of us, to hear that. We love when we know brilliant people are on the case and that they care about this patient population. I'm so glad you were able to give us your background because I would have butchered it. There was a whole lot there. We're so glad to have your expertise with us. And I'm just going to do a little bit of housekeeping first. First of all, chatters, you're already alive and well and chatting away. We're so glad you're here. We want you to ask your questions of Dr. Pennings. And of course, we have our regular anchor panelists. Susie Boshoff couldn't be with us tonight, but we've got Jenny Bougine. Say hi, Jenny. And Patty Cornute, Lipidema Fitness. Angelique Charles, the Lippy Butterfly. Everybody's talking about how your hair is growing, Kara Cruz, Pale Ginger Pear. Lovely to see you all. And we're going to talk about a lot of different things tonight. But again, we do want your questions. First of all, Dr. Pennings, I want to see in chat how many of you saw the Oprah show? Let us know. And did you see it, Dr. Pennings? And did you have any initial takeaways about it?
I didn't see it. Unfortunately, I don't get to watch a lot of television, so I missed that episode. But I'd be happy to hear kind of what your take was, and then maybe I can see how that applies to lipedema, and how I
Well,
think that applies.
a lot of people are saying they felt it was at least validating. I mean, it wasn't about lipedema, it was about obesity, it was about the GLP-1 medications, that it was validating to have so much attention paid. I mean, when Oprah puts the spotlight on something, the world takes notice. So there was that. Lots of people haven't seen the whole thing. She said not everyone with excess weight or larger body size has obesity. So that was an important point. And we want to say from the get-go on this program tonight, we are not for or against anything. We don't ever purport that. Everything is about the choices that you make after doing your own investigation and your own study, and you do what's right for you. Some people choose surgery, some people choose a ketogenic diet, some people choose and fill in the blank. There's no judgment here, but there is so much interest and so many questions surrounding these medications. The concerns about insurance, because one person out there in the audience just said until insurance covers it, only wealthy people can afford it. However, perhaps this is shifting. So I'm going to stop talking for a little bit. And what do you know about the GLP-1s and how they can possibly help the lipedema population?
And I'd be happy to talk about that. But I do want to talk about one thing that I know Oprah has spoken about frequently, and that's about stigma and bias towards people with excess weight. And I think that really is something that needs to be addressed, needs to be dealt with, because so many people are judged and harshly judged for their weight, not understanding the physiology of obesity, not understanding the physiology of lipidemia, not understanding those drivers that promote weight gain are really how our bodies are designed to work. Our bodies are designed to prevent starvation, not obesity. And that is creates tremendous challenges for anybody who's trying to lose weight or to get down in their weight. And you're right, not everybody with excess weight has complications from obesity. Not everybody has disease processes that are associated with it, and we shouldn't be treating to as an obesity medicine specialist. I don't treat to get somebody to some magical weight or magical number. I treat people to get them healthier, and that really should be the focus of any approach, whether it be with medications or lifestyle changes, that the goal is to improve health, not to get into some perceived perfect size or weight. And so I think that was a very important message from Oprah, that we need to be moving away from this idea that, in this gross misconception that people choose to be a certain weight, that they're that weight because they made bad decisions and they won't make better ones. That's absurd and really a lack of understanding of this process. So I
Drop
think that
the mic. That
Yeah.
was so perfectly stated. And I think I see a lot of nodding heads. What are you all thinking, panelists, about what Dr. Pennings just said? Jenny, did you want to jump in there?
I couldn't agree more. I get so frustrated with society's perceptions, but also advertising and media and all of that. And until they change and become more realistic, we're seeing little bits, like Dove soap. But the reality is that perception is out there and it's permeated everybody's brain so much that it's hard to change their sort of wiring that they've got going on, that they're in a bad place. I mean, I've always been big, and really kind of just accepted it and kind of moved on and lived my life. And a lot of people freeze with that and it just doesn't help. So yay.
Mm. Yay. And thank you for speaking to the stigma. Anybody else want to jump in? Angelique, I saw that you were really in agreement with what Dr. Pennings was saying as well.
For myself, right this moment, I'm going through something with my family, where they have stigmatized me as consuming 3,000 calories every day and being completely lazy, and not actually paying attention to the gym or the pool or the cutting out of gluten or sugar and things like that. And keep in mind, I've struggled since losing my mom, and so things aren't as strict as they were a few years ago, but that stigma still rests with people that don't actually understand what we're going through throughout the day. So I liked hearing that, like, obesity isn't just a one shoe for everybody type of thing. We're all going through different things, but it's so hard when you're dealing with the outside world that already has a stigma placed on anybody that has any size on them, that they must be lazy, they must eat a ton of donuts. If you know me, you know I don't like sweets. So the whole fact that people automatically go, well, you should stop eating cake. Like, okay, well, that was a done deal a long time ago. Or they say you should stop drinking soda. I'm like, there's only water in my house. There's no real flour in my house. There's no real, there's no real anything in my house other than what we've talked about as being like good for lymphatic flows and whatnot. So I'm like, there's certain things that have like rested with me, but that stigma still sticks, that I must only consume astronomical calories and just sit on my tail all day long.
Yeah.
Yeah,
Thank you for
and the
sharing that.
data shows that families are the most common source of stigma and bias, followed by healthcare professionals. I'm ashamed to say, and that is really a big challenge that we have. And what I hear in your voice too, though, is that you're not being perfect, and therefore maybe I'm not doing a great job. And I'm sure you're doing a great job, and you don't have to be perfect to be doing a great job, right? You just have to be working at it and in continuously improving and continuously striving to be better. But perfection's the enemy of good, and you really need to give yourself a pat on the back as often as you can for the great work that you do to move your health forward.
Can
I
I
needed to
just
hear that
invite you
tonight, so
back
thank you
every
for
month?
that so much.
You're welcome.
Perfection is the enemy of good. Ooh, that was a drop the mic moment. I thank you so much, Dr. Pennings, for that. And you have an open invitation, by the way, because you're definitely speaking the language that we all need to hear on this panel. Patty, did you want to jump in and say anything? And then I'll go to Pale Ginger Pear, and then we'll get to some of the audience questions.
Yeah, I did catch the episode. I watched it last night, and I didn't learn anything new, but I loved that she was addressing it and, like you said, bringing attention to it. I found it interesting that both the VP of Novo Nordisk was there and Eli Lilly was there, and they've never been in the room together. So that was kind of nice to see that connection. They didn't really talk much to them or about the supply issues that are going on. And what I really, my thing is always the anti-inflammatory and anti-fibrotic nature of these medications. And in the research I've done, I've really kind of tapped into estrogen relationship as well. And so my brain is going down this other path. And so for me, I was like hoping to see some little bit of that kind of coming in. So I didn't get that, but I did appreciate that she was saying no shame and that we need to get past that. And I think that's a really big piece of the puzzle anyways.
Yeah, very good piece of the puzzle. And PGP. You had talked about stigma and done some posting recently about it too, that it's not just about size.
Yeah, it's not. It's people judge with anything. They like you see somebody. If you follow me at all or know, I love the Shamrock Shake. It's that time of year. I will get a Shamrock Shake, and I have gotten so much like DMs and hate messages because I post a picture with a Shamrock Shake, and it's like, I'm allowed a milkshake every once in a while. Little do they know that's typically all I have for the day, which I know is not healthy, but that's a whole other thing. But like, I don't eat a lot, and it drives me insane when people just assume because I randomly post one picture that has some kind of food or drink in it, then it's like, oh, that must be like, her third one of the day every day. And it's like this whole big thing. And like cutting out the one milkshake I get a year is like not going to change lipedema.
I mean, you're a ginger. You're allowed a Shamrock Shake.
Meanwhile, I mean, I should be wearing green and not blue here. I apologize because at least 3 of you are in the whole leprechaun spirit.
I don't have green on either.
Oh,
but it's past the holidays.
I don't know.
So you're safe.
Listen,
right.
I'm near
It's past.
Boston. I have to wear green for the whole month.
I'm a Philadelphia Eagles fan. I should be wearing green all the time, except they broke my heart. Dr. Pennings, we had some questions come in from Patty Cornute's group, Lipedema Fitness. And I also want to encourage all of you in the audience tonight, stick your questions in chat. Whatever answer remember, we're not dispensing any medical advice, just trying to provide information to help support you in your journey. One question was, are these drugs beneficial if you have heart disease but are not overweight? We're talking about the GLP-1 medications. Can you speak to that?
Well, so recently they published a study from the use of semaglutide in patients with a history of cardiovascular disease. Now, we've known that these medications benefit patients with diabetes and have a history of cardiovascular disease and reduce the likelihood of them having a cardiac event. We knew that they had reduced the risk of, or had reduced cardiovascular risk factors. So we see a lowering of blood pressure, we see a lowering of cholesterol, we see improvement in triglycerides. and then improvement in glucose control. But they hadn't done a study on the treatment of those with a BMI over 27 and a history of heart disease using these medications without diabetes. And what the study showed with semaglutide was that there was a 20% reduction in a second cardiac event in those that were taking the medication. That was much more dramatic than we expected, and they just changed the labeled for semaglutide for Wegovy to include an indication for the prevention of cardiovascular disease. So that's a big step forward. That was really one of the biggest arguments that people had against the use of medication, was that there was no evidence that they improved outcomes, and this was a pretty clear outcome improvement.
Okay, well, that's very hopeful. You know, it's interesting to see that, and they did mention in the Oprah special that so many things are interlocked, you know, the diabetes, the obesity, the heart situation, all of that. So another question was, can you stay at a lower dose?
Oop, we just lost her.
Oh, we just lost her.
Yeah,
So
she'll get back in a minute.
just to speak to a little bit more about, you know, that relationship, one of the things that we found is that what we see is that the medications seem to have an anti-inflammatory effect, which is a common thread through many of the different illnesses. I've had women tell me that, you know, their knee pain went away when they took the medication, or they had maybe like a gastrointestinal issue like Crohn's disease or some inflammatory bowel disease, and their symptoms got dramatically better on the medication. A patient with Ehlers-Danlos said her symptoms were markedly better on the GLP-1. So it's not indicated for those things, but that we're seeing, and I think the common thread between cardiovascular disease and diabetes is the anti-inflammatory benefits, or the benefits on inflammation, I should say, for patients that are on these medications.
So some people saw the footage of where the shot goes in, the injection right into the stomach. I think that's off-putting for a lot of people as well. And by the way, this show tonight is not about advocating for or against. We just want information, and we want to provide information to you. Can the injection take place anywhere other than the stomach?
Yes, you can put it in your leg or your arm.
Okay,
Yes,
that
you
might
know,
be helpful to a lot of people.
Yeah, I think the idea, and I mean, I don't know why people have the qualms about the abdomen, because there's, you know, a lot more kind of cushioning there in somebody at any weight with you giving an injection there. And so I guess it's maybe just the thought of the belly, but you can do it in your, you know, the back of your arm or in your thigh.
It's the vulnerable spot. You
And
feel
then we
vulnerable there.
also,
It feels vulnerable. Is that what you're saying?
Yeah, like your underbelly.
Yes.
so then this visual of hair falling out, that freaked a lot of people out, and rightfully so. Do you have any thoughts on that?
So I don't know that that is a concern specifically for the medication. It is something that we see when people lose a lot of weight, especially a lot of weight in a short period of time. So we'll see it with a ketogenic diet. We'll see it with after bariatric surgery. And that tends to be a temporary weight loss. It's more because the hair follicles become fragile rather than lost. And so usually over time, there may be a period of hair loss, but the hair regrowth usually comes back. Not 100%, but very, you know, it's rare that it doesn't come back.
So side effects, other than that, can you speak to that?
So the most common side effects are gastrointestinal. And so you'll have gastrointestinal reflux or heartburn from that. Nausea is probably the most common side effect, occasionally causing vomiting. And sometimes that can be severe. So when they talk about, kidney disease associated with it. It's really those that have severe vomiting that get dehydrated, and that in turn affects the kidneys. It's not something that is damaging to the kidneys. And in fact, in patients with diabetes, they have less kidney disease on the medications than not. Diarrhea, constipation are common side effects that occur that can be managed symptomatically. So can the nausea be managed symptomatically. And the thing is that tends to be transient in nature as well, that the longer you're on the medication, those side effects become less and tend to subside. So I would say that those are the most common side effects. One of the things that always concerns me about these medications is that they're so effective on appetite that people don't eat enough. And it is essential. It's similar to the concept after bariatric surgery. When you have bariatric surgery, you have to follow a very prescriptive diet. And part of that, the initial diet is just so that you recover from the surgery. But after that, it's really to maximize the nutrient quality of your food. And that's how you have to think about eating. It's no longer about getting calories. It's about optimizing your calories that you're consuming. So you want to make sure you're getting enough protein in your diet. You want to make sure you're eating vegetables and prioritize those foods first so that you get the best quality nutrients that your body needs. And then you can add starches and fruits, fruits or starch or other components. But you should eat regularly. Throughout the day, you should eat regularly, and you should make sure that you're getting adequate protein in your diet.
Heidi, you wanted to say something
Yes, I had
or
read
ask.
something. I had read something where they talked about the GIP. So like Mounjaro and Zepbound have GLP-1 and GIP, that the GIP actually can counteract some of those nauseous and other symptoms. Have you heard that or know about that?
Yes, and so the GLP-1s slow how fast your stomach empties, and the GIP tends to counter that to some degree. So some people have less nausea with that combination with the medication that has a dual effect
Gotcha.
than compared to just the GLP-1.
Makes sense.
Did I see some other questions percolating? Go ahead, Angelique.
I just wanted to make sure that I heard you right. Did you say that it had not been researched well with BMIs over 27?
No, that's not what I said. What I said is in that study for patients with BMI over 27 and cardiovascular disease, they had a 20% and they had a 20% reduction in having another cardiovascular event
Okay.
on the
And then my
medication.
next question was, did you or did anybody see any improvement in fibrotic tissue during any of that time? Because a lot of us that have lipedema in later stages, we have a lot of hardening. And one of my questions to my primary care physician when he suggested Ozempic was what it would do for my actual lipedema symptoms. Like, I get that we want me to reduce in size overall, but as long as my thighs are hard and in a solid state, they're not going to go anywhere. Like, I still have to do the other modalities for my lipedema in order for that to do anything. And I've noticed the greatest decrease when I'm actually focused the most on just my lipedema. So my question really here is, where would one of these medications help me if I'm at such a late stage that I'm hardening?
So when we look at the effects of the medications, they have an impact on fat tissue specifically, so our adipose tissue specifically. And the GLP-1s tend to improve the type of cells that are formed and also tend to reduce some of the inflammation that's associated with it. The GIPs help your body make new adipose cells, which is a benefit in that one of the challenges with lipedema is that the fat cells become overly enlarged. And so when they get larger in size, then they don't get the blood flow that they need, they don't get the oxygen that they need, and they get inflamed. And then that inflammation contributes to the fibrosis that you're experiencing. So the goal is to try to reduce that inflammation and hopefully then reduce the formation of fibrosis. I don't know that that's going to reverse any fibrosis that's there, but if it's less inflamed, it's less painful, and that can hopefully help your legs feel better, if not change in size.
We
Thank you.
just had someone in chat say as soon as she started the medications, she felt a softening occur, which is really interesting. We've got so many questions coming in and we appreciate them all. We love you, chatters. We love the questions. I'm going to try and work my way through them quickly. Jeannie Proctor asks, can you speak to the difference in Trulicity and GLP?
Trulicity is a form of GLP-1. It's dulaglutide. So we have, had a number of these that have come out. Liraglutide was the first one to be used for weight, which was the Saxenda, and then the I think dulaglutide came out around the same time as semaglutide did, and they're more potent. They're once a week. They're long. Dulaglutide or Trulicity is long acting, like semaglutide or Wegovy or Ozempic, and it's kind of confusing. There's lots of different names, right? And I don't know if it's easier for me to use the brand names or the generic names. Probably a bit of both. But so for Trulicity or dulaglutide, that is once a week, and so it's a long-acting GLP-1 agonist. Again, it's well tolerated. It doesn't have as robust weight loss data as the semaglutide or Ozempic, which is also known as Wegovy, does. So those are, and that's why it hasn't sought, my understanding, approval for weight loss, and doesn't have it specifically for weight loss. But many people will use it and do well on it. And so it's just another option to be available. It's just not approved specifically for weight.
Sandy Darley asks a really bottom line question, because lipedema patients, many of them are not overeating. So why would this type of medication be helpful?
So that is a good question. And I don't know that we have all the answers to that, because we know it has a benefit for for appetite and appetite regulation, but then it also impacts insulin, which I think insulin is really an important agent in managing and dealing with lipedema, because we know insulin regulates our blood sugar, but insulin is also a key regulator of our body fat. Insulin will increase fat storage. It prevents fat breakdown, triglyceride breakdown in the fat cells. And so really, insulin plays, I think, a very important role in women with lipedema, because I think it promotes the expansion of that lipedema tissue and it prevents the reduction of it. And that's why I think low carbohydrate diets can be beneficial for women with lipedema and help to lose weight. But also these medications, they do decrease intake, they do decrease the quantity of food you take, but I think it's the effects on inflammation in the body and the effects on the adipose tissue that reduces pain and reduces the swelling, and that way can be beneficial for women with lipedema.
Thank you so much for that explanation and for that excellent question, Sandy. Go ahead, Lippy Butterfly.
I'm sorry, I have one more question. I am a fat 80s, 90s kid. And so I was around when Fin originally came out, and obviously the doctors were trying to prescribe that. And so I'm somewhat leery of diet medications. Is there any research that lets us know that this is safe, number one, but also safe for lippy bodies?
And so, in terms of lippy bodies, there isn't data there specifically for that. But, the first of these agents was Byetta, which came out in 2005. So we've been treating diabetes with this class of medication for 20 years. And I think that's a pretty long track record, a pretty long time for people to be chronically on these medications and not manifest any kind of long-term complication associated with that. So I think makes me feel comfortable prescribing the medications to patients and not concerned that I'm creating an undue risk. The fen-phen was, a very kind of unfortunate thing to happen. And I think some of it got a little bit overly dramatized with the idea that people's hearts were blowing up in their chest. That was never happening, but these are the kind of things that you were hearing. It did cause some damage to heart valves, and that damage to heart valves did harm some people, and that's why it was taken off the market. It was a very small percentage of people, but also, kind of going back to the stigma and bias thing, there's no tolerance for any side effects when it comes to treating weight. That there's little acceptance that we should, because after all, you should just be able to do this on your own anyway. Is the mindset of so many health professionals, that they don't, weigh a true risk and benefit. What is the risk that the excess weight is posing on your health, and what is the benefit that the medication can have by reducing that? And I think that's how we should always look at these things.
Absolutely.
Go ahead, Jenny.
So on the insulin issue, if my A1C is really good, how would my doctor know that it might be good for me to use one of these medications to see the, what is it, insulin resistance? Is that what it's called?
Right, insulin, and we're not really treating insulin resistance. For women with lipedema, I check insulin levels all the time, and I don't find insulin resistance. And actually, that's kind of part of the problem. And I'll get a little bit technical here. So if insulin is promoting the storage of fat in the body, in the adipose tissue, and preventing its release, if you're sensitive to insulin, it means it's working really well to do that. It's storing weight, it's storing that triglyceride, is storing that fat in your adipose tissue very effectively, and it's going to be very effective at keeping it from coming out. Right? So I don't find insulin resistance in women with lipedema, because I think they're very effective, and the consequence of that is that your body is very effective at storing calories there and very stingy about removing them.
Yeah, that's a good word for it.
Sounds about right.
We have all different kinds of people that log on. Some have been with us forever, and they almost have PhDs in discussing these kinds of topics. Some are fairly new, and we welcome you as well. We love your questions, and we're here to provide some answers. And we want to welcome you, Debbie Bracey. She wants to know, what's the difference between lipedema and lymphedema? I'm not sure.
So, Kara, did you want to answer that? You had your hand up.
I was just having both lymphedema and lipedema. How I describe it to like my grandmother or when my kid was younger, it's like lymphedema is when the lymph channel is damaged and the lymph fluid can't flow back up properly. So it gets trapped in like a portion of the limb. It could be one leg, two legs, one arm. It could be like 2, 4, it could be all the limbs, and it could be in the abdomen and stuff as well. And it's more common men and women. Lipedema is when the body like overproduces lymph fluid and the fat cells absorb it, and they create the nodules because they're growing with the absorption of it. Lipolymphedema, which is a combination of the two, how I would describe it is when you've got like the sponge that's sitting in a puddle of water and it's soaked up all it can, but there's still water around it, that's when the fat cells have stopped absorbing the overfluid, and then you have the lymphedema effect as well, pulling in your limbs. So that's how I explain it to people that aren't necessarily medical. But
And I think that's a great explanation. I think of it kind of as if you were looking at a tree. And so with lymphedema, it's really a problem in the trunk. So it's going to be something that is going to be in a larger, more proximal vessel, a lymphatic vessel, that's going to cause a backlog all throughout the tree, right? All throughout the tree. Where is in lipedema, it's really more of a problem in the leaves. It's in the tissues itself that the fluid accumulates, and that's kind of my assessment from my, seeing so many women with this condition and examining so many arms and legs and different parts of the body that have lipedema, that I feel it in the tissues. The weight, the tissue feels heavy, it feels boggy, and even though the swelling is not, down in the feet. And then it gets to a point where once all the leaves are full, it's going to start moving into the trunk, and then you get the lympholipedema, so that you get the combination of the two. And so that's how I kind of visualize it medically.
Thank you for that explanation. Someone asked, why is lipedema more prevalent in women? We do know that it shows up in hormonal junctures that men don't have to deal with necessarily, like pregnancy and perimenopause and puberty, in the way that a woman goes through puberty. Do you have a better explanation for that question, Dr. Pennings?
Yeah, I mean, I do think, the estrogen and female hormonal cycles play a huge role in all of that. We just don't really have a good way of explaining it, or how to, we see the association, but we can't fully make the connection as to the cause and effect there. Because there are cases of it occurring in men, but usually in men that have something like liver disease or other conditions that actually cause higher estrogen levels in their body, and then we start to see it in those with a family history. But it seems to be very clearly related to hormonal fluctuations, which we typically attribute to estrogen.
So the injection site, will that make a patient vulnerable to cellulitis?
Vulnerable to
Cellulitis.
Oh, cellulitis. Well, I mean, you have to use aseptic technique. You want to clean it with a, alcohol pad ahead of time. But it is such a tiny, tiny needle, so that most times when you're doing the injection, you barely even feel it. So the needle and because it's so small, it doesn't cause as great a disruption of the surface of the skin, and so it's less likely to cause an infection.
A lot of questions coming in about addictive properties. Once you're on a GLP-1, do you have to stay on it forever? When you go off it, will you gain again? What is the addictive nature of these drugs?
Not addictive at all. I would not, that's not the way to think about this. It's really, obesity is a chronic disease. So if you were talking about a blood pressure medication and you went on a blood pressure medication because your blood pressure was high and your blood pressure came down to normal, and you stop the blood pressure medication, your blood pressure would go up. It doesn't mean you're addicted to the blood pressure medication. It means you're dependent upon it to control the disease process. And that's how we should be thinking about the treatment of obesity with these agents, is that it controls the appetite regulation that is a major factor in the struggle that people have. There's other factors, but that's a major factor. And if you stop the medication, your internal appetite regulators will will go up again, and you'll want to move back towards a previous weight. That's how the body is designed. It's not an addiction. It's just part of the physiologic process.
We believe in transparency here at the roundtable, and I just want to make sure that the panelists are comfortable with this question. But there was a question, are any of our panelists?
Yep, she's gone. So the question was, because I'd seen it earlier, that somebody had asked if any of us on the panel are on GLP medications at this point, and I am not. I have concerns about needing to always have it available, and the supply chain isn't there yet, and getting it covered by my insurance because, you know, I don't have the resources. So somebody else, are you on it? Anybody else? Any of us on it? I don't know.
I'm not sure if I spoke to this at our last roundtable, but my doctor was pushing it because of my 20 pounds of weight gain over the past year and a half since I lost my mom. But I had a lot of questions about it. One of my questions being, if I know for a fact that I have not been eating as regimented as I was when I was losing weight, and I haven't been in the gym and I haven't been in the pool, then what is one of these medicines going to do for me? I'm not saying from a standpoint from most of us lipedema women, we're doing something daily. And keep in mind, I need to give myself a little bit more grace because I still am doing something, but I'm not doing what I was doing. So then my question to him was, is it necessary for me to actually add a medicine, or is it necessary for me to get back into my routine, or do I need to do both? He didn't have an answer for that, not understanding that just because I'm fat doesn't mean that I'm not sitting around all day. It doesn't mean that I'm gorging myself on burgers every single day. And Ozempic being an appetite suppressant doesn't help me. So I needed to know what it actually was going to do for somebody whose meal consists of one piece of fish and green beans. So if I'm already there, I don't need my appetite suppressed. I needed something different. And my doctor could not answer that for me.
And so I think, you know, that there's a couple things sort of to unpack there. It sounded like, you know, you're not eating a lot, but then you're also describing other times when, you know, whether it be the stress or other factors might be contributing to some differences in your eating patterns in there. Is that right? And you know, we all have cravings, we all have desires for foods, and we all are in social situations where food is very tempting. I mean, we live in an obesogenic environment. You know, you want to get together with somebody, you're getting together for lunch or dinner, or you're having a meeting, there's food there. People bring donuts into the office. I mean, it's a constant bombardment with food, and it's hard to not eat those things when you're hungry. That becomes a big challenge. And so the medications, interestingly, you know, not just decrease appetite, but they also seem to have an impact on cravings. What patients will tell me is that it turns off the food noise in my head. That's a common thing that they say, that they just don't think about food like they used to, so that they are, you know, then not, you know, having some of those things that, you know, it's like the broken cookies don't count sometimes, those extra calories that might be creeping into your diet. And maybe they are, and maybe they're not, but at least it helps manage that to stay on it better. Could it have
I
some other
might
effect?
be in the same alignment with a lot of women that come in here, but like I don't snack. I don't actually have food cravings, and definitely sugar is not one of mine. So I really needed to understand what was going to be different outside of my regular regimen. If we're talking about a food craving, it's probably potatoes and cheese. Neither one of them great for me, but if I'm going to fit something into my day in my already small stomach, it's going to be potatoes or cheese. So I don't necessarily need something that's going to help me with my cravings. I need something that's going to help me with where my body is not doing the right thing, even when I am. Where I feel off is like I went from gluten-free flour back to regular flour. We're talking about minor things here, but I'm still, I gained 20 pounds from not going to the gym.
Yeah, and you know, not everybody loses weight on the medication. So that's the one thing to be clear, that, you know, when you look at the data on any medication, not everybody loses weight. But I hear your story, and I've seen people continue to lose weight, and I don't really know why, but also we don't really know why your weight is the way it is with what you're eating either. So, you know, there are effects that may be beyond, you know, the just calories in and calories out. And I know there are effects beyond the calories in and calories out, whether it has other effects that contribute to weight loss. So it may be a benefit. It may not be a benefit for you. You may not be a good or the right candidate for it. But I do find those that struggle with that food noise, I do find that those that struggle with hunger, it is a benefit to them. And even those that don't seem to lose weight with it. And I can't explain that, because I also can't explain, you know, why your weight is the way it is with what you're eating. So there's still a lot of mystery in what we do. And so I think that I wouldn't just look at the calories in and calories out part of the equation to make a decision around that.
Angelique, the stress of losing your mom is going to cause your symptoms to spike. That's my biggest trigger. When my inflammation gets worse and I swell, it's usually around stress. So what I like to think about when I think about these medications, and I've been doing a ton of research. I'm not currently taking them. I am looking into them. I've been doing research for over a year about them to try to understand why they would be anti-inflammatory and anti-fibrotic, because that's what I'm interested in it for. And so our bodies produce GLP-1 and GIP hormones in our brains and in our bodies. And these are helping that. So I don't know, if Dr. Pennings, if you can kind of talk to that. Is it because ours aren't functioning properly? They don't behave the same, and then these medications come in to help them with that? I'm not unsure how that works.
Well, as your weight goes up and stays up longer, you seem to make less of those those agents. They are naturally produced in the gut, and the medications are mimicking those effects. The GLP-1 effect that your gut produces is very short-lived. Does not hang around for a long time, whereas these medications hang around for a long time. So they're probably having an added effect on top of what your body's GLP-1 effects already are doing. And like I said, there seems to be other effects. I don't see legs change in size all that much for most of the women that are on these medications, but many of them will say their legs feel better, that they don't feel as heavy, they don't hurt as much, they're not as tender as they were. And to me, that speaks to the effects on inflammation.
Exactly.
I just want to add, Angelique, too, little changes such as like reduced pool time for as much as you were going, and switching back to a wheat-based flour. Those are two things that can kick inflammation to rise, because you're reducing your compression from the pool, and then wheat or gluten is such an inflammatory for us, like lipedema women and stuff. So you add in those two little factors plus the stress factor, and really then a 20-pound weight gain, which is probably all fluid, isn't a lot with our condition. Like some of us have had spikes of, 10 pounds in a day. Like, so 20 pounds, really isn't the same for us. And we really have to, it's hard to for a lot of us, I know that, but we really have to not try to focus on the number on the scale versus the pain level. Is it increasing? Is our mobility decreasing? Are the inches going up? Is my compression not fitting now? Like those are what we need to factor on more than just the scale jumped 20 pounds. And I know it was the doctor more than you, but like we have to kind of remind the medical community that aren't as into lipedema as some of them, that I can't focus on the scale because of the fluid increase that happens so easily. This is what I need to focus on. And for some of us, it can go really quickly. And so I know, like when I was sick just recently, I had almost a 15-pound weight gain in the course of like 3 days because I wasn't wearing my compression as much. I was inflamed because of the one medication I was taking for my sinuses was causing inflammation. I was a mess. But I knew that as soon as I was done and able to breathe and not cough and everything and get compression back on, it would be right back down. So like you can't focus on like those type of things.
I think
And
you
I
bring
know
up
for me, sorry, go ahead.
I think you bring up a very important point, and that is when the scale changes, if the scale goes up 3 pounds in a day, you didn't gain 3 pounds of fat. That it's fluid that shifts in your body. And that's where a lot of the weight change occurs. But people beat themselves up over day-to-day changes, which may just be, you know, something that was salty in their diet, or changes in their hormonal cycles that are going to result in changes in fluid retention. And that those are things that cause the day-to-day fluctuations of weight. It's not, I'm up a pound, that means I have an extra pound of fat. It's more likely a pound of fluid. You weigh yourself and then you drink 16 ounces of water and you get back on the scale, you'll weigh a pound more, but you didn't gain a pound of fat. You just drank 16 ounces of water that you haven't gotten rid of yet.
Go ahead, Patty.
I had a question kind of off the beaten path here. Gynoid obesity, how is that different from lipedema?
Probably in a couple of different ways. One, the distribution. So gynoid would be female distribution of excess weight, whereas typically, or a female distribution of body fat, I should say, which is going to be around the hips and the thighs and the buttocks. And that typically happens around puberty. And to me, it's lipedema is sort of that process gone wild. It's gone to an extreme, but it's also different in that it tends to continue to grow, to increase, especially during periods of hormonal change. It tends to be, you know, different from regular gynoid fat. I don't see in women that don't have lipedema, I don't feel the nodularity, I don't feel the fibrosis, I don't feel the edematous component. They're not tender. They don't bruise as easily. So you know, all those other components of lipedema, I think are part of that diagnostic process that distinguishes between gynoid fat and lipedema.
So more like a location similar, but that's about it.
Right. The tissue is different.
Got you. Thank you.
Lynette Ten Brimeler, I hope I said that properly, asks, is there anything we can do to get our own gut to produce GLP-1 on a daily basis? She has celiac and mast cell activation syndrome, so she's not able to have gluten or fermented foods that we all know are good for the gut. Any thoughts on that, doctor?
I think that's hopefully an area where probiotics may be beneficial, and specific probiotics that can stimulate GLP-1. That, you know, that is potentially an avenue, but it's still kind of in its infancy of understanding. There is a company that makes a probiotic that's supposed to improve GLP-1. Whether it really does that or not, I don't know, but I think that's a very interesting area of research, and in the hopes that we can try to enhance our own production of those agents.
Brenda, we
We've
can't
had
hear you.
people in chat say, can we just clone Dr. Pennings? So we would like one of you in every city in America, and we are running out of time. So I do always end with a word of encouragement from everyone. But first of all, I would like to ask you, Dr. Pennings, is there anything left unsaid? There's still questions we didn't get to. What do you want the lipedema patients watching tonight to know?
Well, my hope is that there will be treatment options that will be more effective in the future. And we have a whole pipeline of medications that are being looked at that have different effects on different areas of the body. I don't feel like we've hit we definitely haven't hit a home run with the GLP-1 or GIP. But there are some agents that I think hopefully will be helpful to be able to reduce and maybe reverse some of this, but it remains to be seen. There may be some agents in the pipeline that can hopefully be helpful for that. But I think that the most important thing is really to understand that your condition, it's not your fault that your body wants to hold weight where it does. It's how your body is designed. And society will tell you it's your fault, and healthcare professionals will tell you it's your fault. And they're wrong. It's not. It's how your body is designed, and not to beat yourself up, and not to feel like, you're not some if you're not being perfect, then you're being flawed, and that you should never have that shamrock shake. Of course you should. It's St. Patrick's Day, and we should all be entitled to enjoy those things and not feel judged and criticized for being able to partake in the things that we need to do, and at the same time to really focus on your health and trying to eat healthy and be as active as you can and do the things to help yourself. But very often when we have this perfectionist mentality that we have to be perfect or we're wholly inadequate, that just demotivates us because nobody's perfect. And so you're going to have your ups and you're going to have your downs, and recognize that when you're having your downs, you just got to ride the storm out and get to the other side and get back on your program and get back focused on doing the things that helps your body feel better. And I think that is really one of the key things. I find that too often people are just too hard on themselves and they're too critical. There's too much negative talk in their head, that negative talk that's always judgmental and critical and shaming. And so bias and shame, correcting that really begins with yourself. And you have much more control over that voice in your head than you do over that voice that comes from your family or comes from your health professional. So listen to that voice and try to change your thinking about that. Recognize when you're being mean to yourself. Recognize when you're being harsh, because that's one of the things I'll tell my patients is, don't be so mean. And they're like, what do you mean? I said, mean to yourself. If you said the things to other people that you say to yourself, you would be thought of as a mean and nasty person. And
A bully.
you're a bully, right? And so but you can control that and try to change that voice in your head to be more positive and to, I think the key is accepting this having lipedema, that you need to accept it. It's not, that doesn't mean you like it, and that doesn't mean you want, that you're not going to do anything about it. It's just once we accept things, then we can move forward. We can say, okay, what can I do about it now? And I think that's an important part of managing this for the long term.
A doctor who's also an inspirational speaker. We'll take it. We'll take it all day long. We're giving lots right back to you. We appreciate you so much, Dr. Pennings. Any final words of encouragement from the panel to our audience tonight? And I know, Jenny, you had shared a poem with us privately. Would you be willing to share that?
Yeah, I would, because I was reminded today about this Buddhist prayer that I found back at a time when I had lost someone that was very dear to me and I was having a real struggle. And I said this, repeated this chant every day for a few months, and it really made a difference. So it was really the function of the prayer was to connect us with something that's greater than our own self. And you chant it in different ways, but it starts out with, you say, may I be free from fear. May I be free from suffering. May I be happy, and may I be filled with loving kindness. Then you say it again, but focus on someone you love and use their name as you say it. So may Brenda be free from fear. May Brenda be free from suffering. May Brenda be happy, and may Brenda be filled with loving kindness. And then focus on somebody you don't know and insert them into the prayer. So may my receptionist at work be free from fear. May she be free from suffering. May she be happy. May she be filled with loving kindness. And the hard one, then you insert the name of someone you dislike and wish that prayer for them. I'm having trouble finding somebody like that because I like everybody. But you repeat that, and then you go back to repeating it for yourself. And that made such a huge difference for me at that point in my life, and really kind of got my mindset set in a whole different place. And I want to add, this was decades before I learned I had lipedema. But it was really helpful.
I think it's a beautiful way to end. And I think everybody in chat, first of all, thank you. I've had some technical issues tonight, but the panel and the chat continues so beautifully because this is so much bigger than just one person. It's about all of you collectively, the love that we feel for each other and the support that's there. Thank you for the support. I feel it tonight. When you said my name in the prayer, I needed it tonight. Thank you, Jenny Bogine. And so for everybody, freedom from fear, freedom from suffering, and may happiness and loving kindness fill your life in the coming month. We are going to see you next month. We'll see some of you in St. Louis. We'll be broadcasting, we'll be YouTubing, we'll be doing Zooming live from St. Louis, and everybody else will be logging in. And next month, Kaz Talks will be with us as our special guest. Until then, everybody, blessings all around. Thank you.
Thank you, Dr. Pennings.
Thank you, Dr. Pennings.
Yeah.
We appreciate you. Bye-bye, everybody.